This is First Pediatrics. Hi there, my name's Chris.
And my name is Laura.
And welcome back to First Pediatrics. Laura, could you tell us a little bit about yourself?
Oh, sure. I'm one of the pediatric chief residents at our University of Michigan residency program. I'm originally from the beautiful state of Maine. Shout out to New England. I did undergrad at Wesleyan University, medical school at Tufts University. I'll be starting PICU fellowship at Johns Hopkins in July. And while I am not a hematologist or oncologist, I've had some really incredible mentors, both in med school and residency, that have helped me develop my passion for our hemonc patients and their families. And so I'm really excited to be here today to review an important pediatric hemonc topic.
Awesome, and congratulations on your match into PICU fellowship. So Laura, can you remind us about our podcast?
Sure. First Pediatrics is a peer-to-peer podcast geared toward pediatric resident education. Our goal is to address your first management experiences by bringing you evidence-based content to help you on the wards and make daily life more manageable for a resident.
Thanks so much, Laura. And also, could you introduce the topic for today and why you think it's so important for residents to know more about?
For sure. Today, we will be talking about one of those can't-miss diagnoses some providers may fear, a new onset hematologic malignancy. Patients can present with concerns that are commonly encountered in pediatrics, such as nosebleeds, bruising, fatigue, nonspecific pain, fevers, random infections. And it's our job as pediatricians to be able to suss out and provide reassurance versus when to investigate further. Today, we will be reviewing how to evaluate a patient with signs and symptoms that could be concerning for a new onset hematologic malignancy, understand what initial workup needs to be done, review treatment for these patients, and hopefully throw in some pearls about how to best communicate difficult information to patients and their families.
That sounds really great. Do you want to go ahead and get started with the case?
I would love to. So let's say you are an intern who's working in the emergency department. You're pretty comfortable down there. And so you sign up for a new patient who's a 3-year-old male presenting with bruising and fatigue. You open their chart, start a note, you print out their emergency department triage sheet, and you're ready to go. As you're walking into the door, what sort of things are you thinking about?
So I guess with any patient in the emergency department, I want to make sure they look stable before gathering some of the history. One of the ways I do this is by looking at their most recent set of vitals and just look at them from the door. So do you mind giving me the vitals?
Yes. His vitals are really just notable for some mild tachycardia to like the 130s range.
Okay.
But the rest of his vital signs in triage look appropriate for age. And from the doorway, he is not ill-appearing. He's actually sitting on the hospital stretcher watching Bluey on his iPad. So what sort of things might you ask about first?
Sure. So I'd want to know about the time course. Like, when did they first notice the bruising, fatigue? Where is the bruising located? Like, have they noticed any easy bleeding, rashes, like any recent trauma? Also, like, has this happened before? And I always ask, why did they come today to the emergency department?
I love your last question in particular, but let me try to answer all of them. So the family has noticed bruising over the last few weeks, as well as some progressively worsening fatigue. They haven't noticed any rashes or easy bleeding. He hasn't had any falls or other notable injuries, and it has not happened before. And so that's why they came in today. He just kind of been worsening, and he was pretty tired this morning, which was just not normal for him. And so the parents were feeling like, gosh, something seems like it's off, and they wanted him to be evaluated.
Okay.
And Chris, why are you wondering specifically about the location of bruising in association with bleeding or rashes?
So children who are otherwise meeting gross motor developmental milestones, they should have some bruising when they inevitably bump into furniture and things like that. But this tends to be on elbows, forearms, like knees, shins, those locations where you're just most commonly to bump into things. I would be more concerned if it was on like a soft tissue area, like an abdomen, a back, thigh. And this could be concerning for something more like non-accidental trauma versus conditions with low platelet counts.
For sure. And this is not meant to be a lesson on evaluating and working up patients when there are concerns for non-accidental trauma, but it's always important to have those red flag exam findings and history components in the back of your mind. But for the sake of keeping us on track, I'm also going to tell you that on a detailed social history and additional physical exam, there are no concerns at this time for non-accidental trauma. So, what other exam findings might make you think about problems with platelets?
Some of the things I think about is things like petechiae, and that's a type of rash that we think about with low platelets in particular. Any mouth or gum bleeding, a way to ask this is when they brush their teeth, do they have bleeding? Nosebleeds that are out of context of what they typically get could be a telltale sign. New hematuria or blood in the stool would be concerning, I think, to anyone, but definitely for thrombocytopenias or platelet problems. Larger bruises that are typical for like the type of injury they have. And then on an exam, like an enlarged spleen could be concerning for sequestration, for example.
Absolutely. So you go in and you start talking to the family, and they tell you that he's healthy and developmentally typical. He hasn't had any significant past medical history. He's never had any easy bruising, just kind of the typical toddler bruising that you described earlier over, bony surfaces that toddlers typically bump. They now remember with prompting that he started having gum bleeding about 2 to 3 weeks ago when he was brushing his teeth. And over the last 2 weeks, they've slowly noticed more and more bruising on his arms and legs, as I mentioned before. But this is happening without necessarily witnessed trauma. And the bruises are just looking larger than they would expect and had seen previously. He's also had 2 nosebleeds in the last week, which is not typical for him. He usually doesn't have any. So what do you think about this story?
Now, I'm starting to get a little bit more concerned that there's something wrong. Specifically, I'm worried that this is sounding like a platelet problem.
I agree. And when you think about a problem with platelets, there are some common diagnoses that come to mind. Can you think of any that you might start adding to your differential?
Yeah. Well, I think this is all on our mind, a cancer like leukemia, and I just wouldn't want to miss that. Also thinking about things like ITP or bone marrow suppression failure.
Right. And with platelet problems, we can think about them in a few different ways, but a framework that I find helpful is platelet consumption or destruction, platelet sequestration, or platelets getting stuck in the spleen, impaired production, or impaired platelet function. Can you think of some examples of diagnoses that you might add to each of these categories?
Yeah, those are good buckets. So under the consumption or destruction category, I think of things like I already talked about the ITP, maybe a medication-induced thrombocytopenia, DIC, or other thrombotic microangiopathies such as HUS or TTP. In the bucket of platelet sequestration, the one that I think about the most would be overactive or enlarged spleen. Under the bucket of impaired production, bone marrow suppression is certainly one, bone marrow infiltration, nutritional deficiencies, inherited platelet disorders, liver disease, all of these things could contribute. And then also under that impaired platelet function, things like IgA vasculitis, like Henoch-Schleien purpura, could be on the differential here, or, inadvertently taking grandparents' blood thinners, for example. Like, this is not supposed to be an exhaustive list, but just some of the things I think about.
Absolutely. And I think that's a helpful framework for evaluating a common pediatric problem, bruising, and trying to evaluate for some of the red flag history and exam findings. Okay, Chris, let's get back to our case. So we reviewed the bruising and some exam findings you want to specifically evaluate for. Do you want to hear about the rest of his exam?
Yeah, let's do it.
Okay. So he is generally tired appearing, and you are an excellent budding pediatrician, and you know that some of the best places to assess for pallor are by looking at his conjunctiva, his nail beds, his palms, and his buccal mucosa. You feel like his conjunctiva look pale, but you don't appreciate any scleral icterus or yellowing of the white part of the eye. You think you can feel a spleen tip, but you're not the most confident in that. You are confident, though, that you feel several palpable lymph nodes in the bilateral anterior and posterior cervical chains, without any that are particularly enlarged, firm, or fixed to the surrounding tissue.
Okay.
What do you want for further workup at this point?
Yeah. So I first would want to start with a CBC with differential to evaluate the other cell lines, so white blood cells, hemoglobin, hematocrit, as well as the platelet count. If I'm truly worried about a possible hematologic malignancy, then I'd also want to get electrolytes such as, magnesium, phosphorus, potassium, and then also get a uric acid and LDH. I also may choose to get a peripheral flow cytometry and a smear as a possible second tier test if we're really concerned about a malignancy from those first line tests. I also might add some labs if we're worried about platelet consumption, such as a hemolytic process. So I know we already will have that bilirubin level and liver enzymes from our complete metabolic panel, but also maybe getting a haptoglobin and DAT and a type-in screen if we're at all worried about hemolysis. I do also like to get those coagulation studies to see if there might be another reason for bleeding, such as a PT, INR, and PTT. And then I also do get a reticulocyte count to get a better sense of how bone marrow production is going for red blood cells.
Perfect. So you get all the labs back and you note the following pertinent positives. So the white blood cell count is 61.4. The hemoglobin is 8.5. The platelet count is 12. His ANC is 500. His LDH is greater than 900. His uric acid's 4.2. But the coagulations that you asked for and the rest of his comprehensive metabolic panel look okay. Based on that CBC, now what are you thinking and why?
Unfortunately, I'm now very worried about cancer. The fact that his white blood cell count is high, but the other two cell lines, hemoglobin and platelets, are low, suggests that potentially this elevated white blood cell production is actually affecting the normal function of his bone marrow. Plus, the high LDH does suggest rapid turnover of cells, which we can see in malignancy and hemolysis. Luckily, the uric acid and electrolytes are normal at this point in time, so I'm not necessarily worried about active tumor lysis syndrome. And, fortunately, we did review this before in our febrile neutropenia lecture with Dr. Annie Bolt. So if you have more questions about that, that might be a good resource for you too.
Yes, we love Dr. Annie Bolt. What a great plug for the content that she reviewed for the podcast. And yes, exactly as you said, a hematologic malignancy should now be at the top of your differential. The white blood cell count can be high or low, but classically, you will also see issues with your red blood cells and your platelet production. And I've seen cases in which the bone marrow is just so packed with those blast cells or immature white blood cells that the other cell lines may not yet be dramatically impacted out in the periphery, but the bone marrow biopsy showed a lot of blasts in the marrow. And so I think there are two important teaching points. So the first is that you're ultimately looking for blasts. And the cell line might being low or high might tip you off, but you also need to make sure that you're investigating in the right places. So you look in the periphery and you're going to get your flow cytometry. That's going to give you more evidence about what's happening in the periphery. But like I mentioned before, that bone marrow might be packed with blasts and the blasts might not yet be out in the periphery. So you have to make sure you're looking in both places to try to find those blasts. And if you are truly worried about a hematologic malignancy, this brings me to point number 2, which is that even if there aren't obvious blasts in the periphery, it doesn't rule out cancer. And so if your clinical suspicion is really high, you still need to make sure you do the bone marrow biopsy to look there.
That's really good to keep in mind. So we did order a peripheral smear and flow cytometry after getting the labs back first. Do you want to share what those results were?
Yeah. Unfortunately, this patient had 68% blasts on his peripheral flow cytometry. What do you want to do next?
First, I would want to take a deep breath. Second, I definitely want to let the attending know to make sure we're on the same page about the testing results, and then reach out to our HEMOC team as well.
Absolutely. And I think you made such a good point about making sure that everyone on the care team is on the same page, because the next part is really difficult and also really important. Let's say you're the provider who now needs to tell this family that you're worried that their child has cancer. It's like one of the most feared conversations in all of pediatrics.
Mm-hmm.
How do you approach that conversation?
Back in medical school, I did learn a helpful approach to break bad news, just generally, the mnemonic being spikes. I appreciate that. You might have your own typical approach, and it's just good to have a framework of how to approach these conversations. But to walk through the spikes mnemonic, it's usually very good to have a good setup for S. So making sure that all the right people are in the room, that you're able to position yourself well, and that you're in a good place to have that conversation, like phones off, maybe pagers in a different place. Then perception for P. You ask the family about their understanding so that they can share with you what they know so far and you don't make assumptions. The third one for I in spikes, invitation, is letting them know that we have some initial lab results and how they would like to receive the information, or if now is a good time to share that information with them. Something else to point out is, depending on the age of the patient, some families might like to have this conversation separately. And sometimes child life, for example, could help to watch the child as you're having a conversation with family. The K in spikes is for knowledge. A nice way to potentially share this could be saying, while we all hope this is not cancer, or we wish this wasn't cancer, we're worried based on what the labs are showing that this is a real possibility at this point in time, and therefore we need to do some additional investigation and tests. After sharing this information, we get to the E in spikes, which is emotions, empathy, which means letting the family have time and space to sort of take in this information, to listen to their hopes, fears, worries based on the information you just shared. And then in terms of the S is to summarize the conversation after you've given them some time to make sure that you've reinforced what the next steps look like. I think it's also worth mentioning that families often don't remember what you say when you break bad news, but they rather remember how you say it.
I love the spikes mnemonic, and thanks for reviewing it with us. And I think that all of the points you made are so important to keep in mind. And I was taught as a medical student to not underestimate the value of a good setup, and making sure that you have thought through how you want that conversation to look can really make such a difference in how the conversation goes. Okay, you've broken the difficult news. What are some of the additional next steps you should be thinking about, and or what might you tell the patient and family about during that conversation?
Yeah, so I would want to get a chest x-ray to evaluate for a mediastinal mass. It sounds like they don't have a fever, but it also might be a good idea to prepare the family for the potential scenario if he does develop a fever, that we'd need to get additional labs, start antibiotics to help protect him from potential infections, knowing that he's neutropenic right now. So I think the things you want to think about is talking about transfusions as well and obtaining consent for blood products, because this might be necessary in the near future.
Absolutely. And thanks so much for mentioning the chest x-ray. It's a really important step in the workup. And luckily, his is within normal limits. Specifically, there's no widening of the mediastinum to cause concern for a mediastinal mass, which you're more likely to see with something like a T-cell, ALL, or a lymphoma. But I love the forward thinking and preparing the family to take fever seriously, as well as talking about transfusions. Are there transfusion thresholds that you typically think about in a previously healthy 3-year-old male?
Yeah, I usually think about transfusing packed red blood cells for a hemoglobin of less than 7, or if they're symptomatic, thinking like they're getting dizzy when they stand up, they're just really fatigued. The other thing is that the platelets are less than 10, or if they're having symptomatic bleeding, such as really bad nosebleeds, gum bleeds, or other like bleeding into an organ space. I think it's also helpful to mention that in children, we typically transfuse packed red blood cells or platelets around 10 cc's or milliliters per kilogram at a time. If a patient is closer to 30 kilograms, however, it may make more sense to order 1 unit of product, since 1 unit is between 250 to 350 milliliters. And that's because all blood products are from human donors and range in volume. As you can probably guess, if you ordered 10 cc's per kilogram on a larger child or adolescent, you could potentially give much more product than you intended. Or if you gave a unit to a smaller child, the same thing could happen. You could just give way too much.
Yeah. And if one of the things that we're thinking this patient might need in the near future is a bone marrow biopsy and a lumbar puncture, does that change how you're thinking about your thresholds?
Usually prior to procedures, we do try to get platelets above 50. This might depend on the type of procedure and the risks associated with those procedures, knowing like, for example, with an LP, you risk bleeding into the spinal canal. So that one for sure, you'd want to make sure that you're above 50.
Perfect. And what is one thing that you don't want to forget when you're ordering blood products for a patient in whom you suspect a new leukemia?
Yeah, so the blood products would need to be irradiated, meaning that we'd want them to be treated with radiation to prevent any transfer of cells into the patient that may have DNA, such as leukocytes, which we're not trying to give this patient. This can prevent transfusion-associated graft versus host disease.
Exactly. Okay, so we have talked about some important considerations for pediatric patients with a new leukemia. And to keep us organized, we can think about these effects in terms of which cell lines are impacted. And I love this framework. It was taught to me by one of my most favorite mentors in med school. So here we go, Dr. Stanley Chaliff passing this on. So when the white blood cells are impacted in a new leukemia, we think about the immune system suppression and dysfunction and susceptibility to serious infections. I also want to mention that if the white blood cell count is greater than 100,000, we call this hyperleukocytosis. And about 10% of ALL cases and somewhere in the range of 5 to 20% of AML cases will present with this. And with hyperleukocytosis, there's an increased risk of mortality if the presenting white blood cell count is greater than 300,000. In general, hyperleukocytosis can be problematic because the presence of all of these white blood cells in the periphery actually increases the viscosity of blood, which in turn increases the risk for complications such as thrombus formation. And we care about this most in small vessels, and in particular CNS vessels, where this can lead to stroke. The other big complication, which you have alluded to, is electrolyte abnormalities when these white blood cells turn over. Blast cells turn over quicker than our normal white blood cells, but particularly once we start to cause intentional lysis of these cells with our treatments, that's when we're at higher risk for developing tumor lysis syndrome. So those are some of the things to keep in mind when we're thinking about the white blood cell lineage. Moving on to the red blood cell lineage, we think about complications such as anemia, and when we have decreased oxygen carrying capacity and subsequent tissue hypoxia that can lead to end organ damage. That's the biggest thing we're trying to prevent here. The other important consideration to be mindful of is how much blood we transfuse to try to help troubleshoot this anemia. So a lot of the patients that present with a new leukemia have likely had some smoldering symptoms for weeks to months and didn't just develop an acute anemia overnight. And therefore, we want to think about giving smaller aliquots of those packed red blood cells when we're transfusing in these situations so that we don't give them too much too fast and cause a high output heart failure. And then moving on to our platelet lineage, obviously the big concern here is bleeding. And specifically, we care most about bleeding in places like the brain. We also worry about prolonged bleeding that we are just not controlling well with application of pressure. And obviously, we need to stop that bleeding. And so giving platelets is the best way that we can help troubleshoot that. Okay, Chris. So this little buddy is getting admitted. You've talked to the family about your concerns. You've ordered some additional tests. You've appropriately alerted the oncology team. You've thought about possible acute complications of a new leukemia diagnosis. And now it's time to admit to the oncology team. Let's switch hats for a second and pretend you're now no longer in the emergency department and you're on the oncology day team. The night team comes in and signs out this new admission to you. What are the things that you need to make sure you're doing for him early on in his first hospitalization?
We already alluded to one thing about transfusion thresholds, but I think this patient's going to need a sedated lumbar puncture and a bone marrow biopsy.
Yeah. And so we're going to proceed with getting a bone marrow biopsy because even though we found blasts in the periphery, we still need to evaluate the bone marrow because we will go back, and part of ongoing evaluation of these patients throughout their treatment course is going to be looking at the bone marrow for evidence of disease. And so we need to prove that the disease is there. And then we also need to look in the CSF, which is why we're going to do that lumbar puncture. Because if there is any presence of blasts in the CSF, then those patients get classified as having disease that has spread to their central nervous system, and they are risk stratified and put on different treatment protocols.
One interjection I just wanted to mention, we do not do LPs randomly on patients with concern for an oncologic diagnosis, as there would be a concern for seeding the central nervous system. Oftentimes, we give a dose of intrathecal chemo or chemo to the central nervous system as we do an LP to help prevent this complication. Also, when interpreting LP results, we oftentimes need to pay special attention to the number of red blood cells in the CSF, as that can play a factor into the larger discussion about the possible CNS disease versus a traumatic tap.
Okay, Chris, can you think of any medications that we should not give to this patient?
So, one, I wouldn't give NSAIDs, given their low platelets and difficulty with coagulation as it is. And then I typically avoid giving steroids to any patient prior to them being on a chemotherapy regimen. Can you remind me, though, like why we avoid steroids generally?
Absolutely. Gosh, thank you so much for bringing this up. It is like one of the most feared things for a pediatric oncologist is to have a new leukemia or lymphoma that has recently been treated with steroids. And the reason being is that steroids are a part of the treatment plan for those types of cancers. And so you worry that if they were exposed to steroids, a treatment agent, but not in the appropriate dose or duration in which they are used as part of their treatment protocol for their disease, that some of those cancer cells might have gained some sort of resistance to one of the cornerstone treatment measures. And so we worry about them receiving steroids, in any of the preceding weeks to months before this diagnosis is made, because if that is the case, then unfortunately their disease gets upstaged and the chemotherapy that they then need to receive as part of their treatment often is more than otherwise and sometimes for longer durations. Is there anything else in terms of lab monitoring and things to avoid tumor lysis syndrome and its complications?
Yeah, so they're likely going to need IV fluids running at a good rate to help their kidneys flush out the breakdown products of cells. So thinking about, the potassium, phosphorus, LDH, uric acid levels. And I'm thinking about to avoid kidney injury in particular here. And then as we're seeing them, we want to monitor the uric acid levels and these electrolytes on a semi-frequent basis. It depends on the clinical scenario, but usually, 3 to 4 times a day is usually appropriate. And then we usually think about adding medications to help with preventing the buildup of uric acid.
Absolutely. And there are two that we think about in particular. Do you remember them?
Yeah, in terms of the pathway, I think it's actually helpful to think of them alphabetically. So allopurinol, the first one, helps prevent uric acid formation, whereas the other medication, resburicase, is further along in the pathway and help to promote uric acid breakdown or excretion. So if, let's say, your uric acid is already really high from a lot of breakdown of cells, allopurinol is not going to actually help with that. And resburicase then would be the mainstay treatment, but you oftentimes use them together to help prevent further buildup of uric acid. The other consideration we have for resburicase is it tends to be very expensive since it's an enzyme. So if we can do it safely, we typically try to just use allopurinol if we know that we're going to start chemotherapy.
For sure. And do you know some of the patients in which we think of being at higher risk?
Patients with Burkitt's lymphoma are often thought to be at extremely high risk for tumor lysis syndrome. The other high-risk patients include the T-cell ALL and B-ALL with presenting white blood cell counts greater than 100,000. Also AML with presenting white blood cell counts greater than 50,000.
You got it. Yeah, that's exactly right. Okay. So what other things are you thinking about early on in an admission for a patient with a suspected new onset leukemia?
So they're going to need some sort of long-term access. So I'd like to discuss with pediatric surgery that they will likely need a central line. It's oftentimes nice to coordinate this with sedation such that they can maybe get an LP, a bone marrow biopsy at the same time. And then we also like to coordinate an echocardiogram. And depending on their age, it might be important to do it as they're waking up from anesthesia so that they can tolerate that procedure as well.
For sure. I think it's really important to get that echo so that we have a baseline assessment of their cardiac function. Chris, this is important because there are a few chemotherapy agents that particularly carry a associated risk with developing cardiac complications. Do you remember the names of any of those?
I think they both start with D. Is it doxorubicin and daunorubicin? And I believe they will receive continued echocardiograms throughout the rest of their life after getting those treatments.
Yeah, that's correct. Is there anything else that you would think about doing for this kiddo in the early days of his first admission?
Yeah, since it's a male patient, I'd want to make sure I do a thorough testicular exam. It's a hiding place for a lot of cancers, just like the blood-brain barrier. There's a blood-testis barrier as well that we need to take into consideration. The other thing that we want to think about is having other support staff involved, like social work, a nurse educator, child life specialists, mental health providers as well, as this can be a really scary time and a lot is happening all at once. So it can help families sort of go through that initial admission process.
Absolutely. And we love a holistic approach, and I totally agree with all of that. And while I am not an oncologist, so I will admit my limitations here in talking about some of the details of treatment protocols. I do want to mention that the Children's Oncology Group developed protocols for treating all types of childhood cancers, and many patients who actively receive treatment for their cancer are simultaneously enrolled in a study. These studies actively look to improve the current treatment protocols by examining efficacy of different treatment modalities, different chemotherapy agents, the doses of drugs that have been shown to be effective against the disease. So, for example, over time, we know this drug works. Can we use less of it? And if the patient or family does not want to be enrolled on a trial, they likely will still be treated according to an existing protocol that we know has shown to be efficacious in the past. When we follow these treatment protocols, the team will help develop what are called roadmaps. And these map out which procedures and labs and medications, including very specific patient calculated doses of those medications, and tell you when they need to be performed or collected or administered all throughout the treatment course. I want to mention that treatment for ALL and AML are different. And without going into the nitty-gritty details about that, because it could be another entirely separate podcast in and of itself, big picture, what I want you to understand is that patients with ALL will require hospitalization and frequent clinic visits for chemotherapy, usually throughout the first 6 to 12 months or so of their treatment course. But then they will enter what's called their maintenance phase of their treatment course, and they begin receiving oral chemotherapy at doses that are not designed to cause significant immunosuppression. So they often can return to things like school and have less frequent appointments. And that phase usually lasts for about 2 to 3 years. In contrast, patients with AML spend a significant amount of time admitted to the hospital during the early phases of their treatment course. They receive really high dose chemotherapy that is supposed to cause significant marrow suppression. They require weeks to month-long hospital stays, and they have prolonged periods where they're awaiting their blood cell counts to recover from that highly cytotoxic chemotherapy. And in those periods, they're at really high risk for contracting serious infections and require frequent blood transfusions while awaiting that count recovery. So the course for patients with AML does look slightly different than ALL. I think it's important to keep in mind that ALL accounts for about 75 to 80% of childhood leukemia, whereas AML accounts for about 20%. And then any of the other leukemias that may be seen in the adult population are pretty rare in children. And the disease incidence for ALL has a bimodal peak. And so the first peak occurs usually between ages 2 to 5 years, and the second peak occurs usually during adolescence. Disease incidence for AML tends to be a little bit more steady throughout childhood, with smaller peaks in early childhood and late adolescence. I also want to make sure that we highlight, while talking about cancer, that we have come such a long way in how well we are able to treat leukemia. And so for B-cell ALL, patients who are risk stratified to low risk disease have a greater than 95% 5-year event-free survival rate, meaning at 5 years after the completion of their treatment course, there's a greater than 95% chance that they are just out there living their lives and doing well without complications or disease relapse. That event-free survival rate does decrease slightly for patients who have average risk disease. It drops to 90 to 95%. And then patients with high risk disease have a slightly lower 5-year event-free survival rate that's closer to somewhere around 85 to 90%. All of this is to say that cancer is a scary diagnosis, but we've come a really long way in treating and managing it in the last few decades. I also want to mention that for AML, that 5-year event-free survival rate has increased to about 60 to 70% for all comers, which is dramatically improved from a few decades ago. So hopefully these statistics provide some hope for you that as medicine continues to advance, we have gotten better at treating cancer.
I think that's such a great sentiment to end with. Thanks, Laura. Just to review some of the key takeaways from this episode, hopefully you understand some of the common signs and symptoms concerning for a new hematologic malignancy. You should be able to think about the differential of abnormal bruising and make sure not to forget non-accidental trauma. We discussed the first-tier tests, including labs and imaging, when working up a possible cancer diagnosis, and some of the complications such as tumor lysis syndrome, hyperviscosity, and febrile neutropenia. We also discussed an approach to breaking bad news to families, such as using the spikes mnemonic. We also highlighted the care plan for a patient with a new onset leukemia when admitted to the hospital, including lab monitoring, obtaining central access, getting a baseline echocardiogram, and considering an LP. In addition, we talked about AML and ALL and key differences in treatment and outcomes. We hope this episode gives you more confidence when approaching care for a patient with a new oncologic diagnosis and gives you hope given the advances that now exist in the care of children with cancer. I want to extend a special thank you to Laura for designing this episode and doctors Jody Ehrman and Emily Jacobson for fact-checking this episode. Thanks for joining us on First Pediatrics, and we'll see you again soon.